Tēnā tātou, kua hui mai. Tēnei ahihei. Can you hear me? How does that sound? Is that better? Can you hear me down the back? Right, tēnā tātou, kua hui mai. Tēnei ahihei, I rungi I te kaupapa kotahi. Tēnā koe te kaiwaiata, I rungi e tūhono nei, I rangi ki te whenua. E mihi ana ki te iwi kāinga ko Ngāti Whātua me ona hapu. E tēnā koutou ngā kai whakahaere o NEAC, no mai haramai. O tira, tēnā koutou, ngā hoa mahi, tēnā koutou, tēnā koutou, tēnā koutou katoa. Marianne and I are going to talk about the locality authorisation and process, and Marianne's going first.
Which one moves the slides up?
You can just try that one space.
Oh, marvellous. Okay. Kia ora everyone. Helen's invited me to just do the first slide of our talk, and what it's going to be about is locality approval. Now, I suppose what my job is here is to maybe just raise some consciousness about the difference between ethical approval and a locality approval, and the locality approval I'll be talking about today is DHB locality approval, specifically Auckland DHB locality approval. I think we all recognise that sometimes the DHBs will have different ways of carrying out locality approval, but essentially we're all trying to do the same job. And the job we're trying to do is a complementary yet overlapping process, with ethics being the thing we overlap with and are complementary to. So if you want to think about locality, it's sort of more about the safety of research participants in our specific environment, our DHB. So I've only got to, so it's a separate thing to ethics, but it is a component of ethical approval. So that might be, so that's one of the ways in which New Zealand has quite a complex ethical environment. But at a DHB, you're not truly, you don't have ethical approval for your research until you've also achieved the locality approval. So the sorts of things that we ponder are specific to our locality, and I take the part of the locality process in my team, which I'll term the institutional approval process, which is quite a specific process and relates just to the part of the hospital, the DHB, where the research is taking place. Helen's process is much broader and more principles-based. But the key thing that I have to tell you about is that everything we do is supposed to have patients at its core. Now, just for fun, we've put the slide in because it's actually showing what our true approval process actually really does look like, and this was after it was streamlined in 2012. But I'll move on to making it just what I want to show you today. So what happens is, somehow or another, the investigators will make the fact of their project known to us. This will either be about contacting us directly normally or via email. Now, we've got a risk-based process, much the same as ethics has a risk-based process, but what we think of as risks are slightly different to maybe you would think about as risks as an ethics process. Now, we don't think that research is inherently risky. We know that mostly it's only about as risky as receiving medical treatment at the best of times. But what we have to consider is aspects of risk that maybe wouldn't be discussed at the research committee, like the safety of participants perhaps who are not in the study. So for instance, if you're a group of surgical researchers and you might want to be doing something in the surgery to consented patients that's going to take the procedure 10 minutes longer, well, what sorts of things we've got to consider is, will the theatre ever get back on schedule after losing that 10 minutes? And could this actually result in somebody who was due to have surgery at the end of the day not getting it because the research interfered a little bit? So that's the sort of review that we're typically doing. Now, if it's very low risk, we have quite a quick process which we call expedited, which means there's only really one pair of hands, usually myself at Auckland gets to read it. But for the things that have a profile that is going to likely to impact the organisation slightly more, and we have to do a thorough consideration of whether or not there are parts of the study that could involve resource utilisation, or that perhaps we don't have a sufficient funding for within the envelope that the researchers have managed to put together, we need to consider those things. We probably also put a bit more emphasis on the scientific review than would go on within an ethics review process. So our research review committee, for instance, is empowered to provide scientific peer review in its own right. So that's one of the, I suppose, value addeds for people coming through a locality process. So in a typical meeting, and they're typically monthly, my team would organise for the applications to be gone to our research committee, which is full of really people with lots of expertise in research across a broad range of hospital disciplines. And what we do try to do at those meetings is, if possible, get to a yes. So what we'd prefer to just approve things outright in a meeting, because anything that's got to go back with recommendations or changes tends to entail a process with quite a lot of transactions that can take a while to resolve. So we do try to get to a yes at the meeting. If the project doesn't quite get that to that stage and does not meet our criteria for approving it, what will happen is it will go back to the research team with recommendations and advice about how to resolve those issues, and that will be handled by our team, and they'll have transactions with the researchers, and they might need to go back to the committee for some feedback. In most cases, those issues are addressed outside the meeting, and the approval letter will then be sent within that cycle between reading it at the one meeting and reading it at the next meeting. On rare occasions, we can't seem to resolve those issues outside a meeting, and so the application would have to come back in revised form to be reconsidered. Now, if we can't, those issues can't be sort of sorted out in revised form, at that point would send a declined letter. But I will tell you, we probably send fewer than 8 declined letters per year. And we receive more than 350 applications. So it is a process that has been able to meet most people's needs so far, and this sits back to back with our Māori approval process, which Helen will talk about now. So please, welcome, Helen.
Thank you, Mary. For those of you who don't know me, I'm the Director of Māori Health Research across the Waitemata and Auckland District Health Boards. I'm a community psychologist, and I was brought on board to set in place a infrastructure that would keep both DHBs running smoothly. So within the 2 district health boards, the Māori review process is a legislative requirement and is locality specific and has whānau at its core. So in terms of legislation, for me, it comes from out of the treaty and the Public Health and Disability Act. When I talk about locality specificity, it's not just about working across 2 district health boards and 5 hospitals. It's also talking about mana whenua as the local tribal authority, and Mātāwaka, which is the urban Māori authority, or Te Whānau or Waipareta Trust. So within those contexts, I need to know what Ngāti Whātua is wanting in terms of the research activities, and they have an MOU with both the district health boards that gives a certain amount of flexibility in terms of research. Te Whānau Waipareta Trust are made up of Māori who don't live in their tribal boundaries and live in Auckland specifically, and they're a very busy trust. Now, the difference between most of the research processes is that most of the research I see focuses on the individual, and I know as a Māori that it's more than that. For us, it's about whānau. So while Māori have a right to agree to participate in a research project as an individual, Ngāti Whātua has a right to have some say in how things are managed. This is my review process. So when and I'm only talking here about the Auckland District Health Board, while I work at Waipareta, at Waitemata, there are 2 different processes. So at the Auckland District Health Board, I get the review applications from the research office once they've been through all the kind of agreements that need to be reached. And if it meets the criteria, which I'm going to start to talk about and which Nick's mentioned to some degree, then a letter gets sent to the research office, and then the investigators are allowed to proceed. And at this point, I'd like to ask any of the team who are part of this process to just pipe up if you want to. I was just looking at Mary, who's one of our teams. And for those, when it does not meet the criteria, but eventually they either do through discussion or they'll get a declined letter. And I say that it takes 21 days to turn this process around because I work across 5 hospitals, but we can usually manage it a lot quicker, usually within a week, unless something else comes up, like December and January of this year, where we've had so much stuff to do from the ministry. I don't know what's going on down there, Nick. We have an ethical dilemma process within the Māori review process. As you can imagine, there's tensions between tikanga Māori and the science world and clinical trials and numerous other things. So one of the ethical dilemmas that I'm thinking of is I received an application from a researcher who said he didn't have to gather ethnicity data. So I sent that out to representatives from our Māori Research Committee, who, and one of them sits on HDX, so she was able to provide us with some robust comments, which I fed back to the investigator. And the thing that impresses me, I think, is that once I explain things to them, they're very happy to include them and move forward. But and there's another. Then there was another one, and Nick mentioned the heart registry at Auckland District Health Board, and at the Auckland District Health Board they have a governance group that looks after the baby hearts and the registry. And one day, one of the researcher wanted to use those baby hearts to do some research that would help train cardiologists. And the dilemma was that as the governance group for the baby hearts, we weren't allowed to move them from the hospital, but the researcher needed to take them to the University of Auckland to use some MRI equipment. And so the governance group, the chief advisor tikanga, and the legal team had discussions about how we would manage that process. And at the end of that conversation, it was decided that we'll write a clinical policy, and that policy would look after the baby hearts as they moved across into the University of Auckland site, and that we'd write a tikanga policy that would keep those baby hearts safe spiritually as they moved across. I think the study's just finished. Now, one of the things that I found quite profound was that our chief advisor tikanga said the kaumātuas would keep that karakia going over those baby hearts as the research went on, and I think we only just finished it, so that's nearly 3 years. Similar process to approving and declining. Now, I think of this as a day in the life of a Māori reviewer, and so I'm just going to talk about some of the thoughts that come into my head as I read applications. And when I get an application, the first thing I ask myself is, does anyone on this team have whakapapa connections? Because I know that if they do, then a lot of the issues that I might have to look at thoroughly, I no longer have to, because they'll probably have connections into iwi and hapu. They probably know tikanga practices and how to manage that in a research domain. Hopefully they'll be researchers, and that would make it even better. And the other thing I think is, if they can speak te reo, then that opens the doorway to mātauranga Māori, and things just, when you have that knowledge and that process, things just run a lot more smoothly. The other question I ask myself is, does the investigator have a relationship with Māori? And some of those relationships might be reciprocal. Can you hear me? And when I think of reciprocity, when I'm working doing research with Māori whānau. It's just a normal part of my practice to take something. And sometimes it might be food, and sometimes it might be a book I know they'll be interested in, and sometimes it might be, research findings that are going to improve the health of their families. The other one is collaboration. So, are you working together as equal partners, or are you going in there to tell Māori what to do? And the other one is kawanatanga. And I just want to talk about a project done, I think it's completed, by Jocelyn Beneta, who's a cardiac researcher at Auckland District Health Board, and the way that she managed the process for this study. So she found in the course of her work that 3 people had turned up, and they all had this particular inherited trait, and she recognised that it was an inherited trait that meant whānau, or people from that hapu, were dying of cardiac disease and dying, around about 30 years of age. And she realised that this was really important. So she called a hui with the whānau, their hapu, and she had the hui at the marae, their marae, and she took her team with her and a kaumātua. And at that marae, and this is reciprocity in play, she talked about her journey as a Jew, and that opened up discussions for people to share, whānau to share their kind of stories as well. And she had the medical team there, the GP from that looked after this whānau, and she's able to explain to the GPs what the outcome of this condition was. But the biggest thing, I think, is that she gave all this knowledge to the family, and she gave the process of looking after that knowledge to the family. So the family set up a website. They've got information pamphlets that go to their family members, and they say to their family members, your children need to be checked for this condition, because otherwise they're going to die when they're 30. And I just want to read you something that one of the family members said to her. I have the genetic mutation, and my 13-year-old son has very high cholesterol levels. My GP referred him to the hospital paediatric department for testing and surveillance. I had to take 2 days off work specifically for an appointment because of the distance to the hospital. When we arrived, the doctor told us she didn't know why he was there, because he has no existing heart disease. I proceeded to tell them about this condition. Notice I'm not saying it. And how we now know the specific mutation, and it's great news for our family. I explained that my son is on a statin, even though he is a young boy, and our understanding was that he needs to have his heart health and progress monitored very closely. I also said that he needed blood tests for the gene. The doctor looked at me dumbfounded and was embarrassed. She apologised, arranged a blood test and booked another appointment with another specialist. In my mind, that's kawanatanga in practice and tino rangatiratanga. The other one for me was, investigators might have relationships with Māori, but what kind of relationships are they? Generally speaking, the one for, I'd say 65% of the research projects I see, which are clinical research trials, their relationships are with the family, and that exists when they're going through the informed consenting process. In my mind, it's a very kind of weak relationship to be having, but it's still important. I'm going to talk about another type of relationship. In 1988, Professor Stephen Robertson was approached by the Tito family and asked if he could find out why their babies were dying. So it took him many years for him to find out what it was, but the nature of that relationship continued through the years. So in 2016, 2019, I met one of her students, and that student was a member of this family, and he was training her to be a scientist so that she could better look after her family. And I can't remember what the name of the condition is, but the babies are born deformed, or the mothers miscarry before the babies are born, and the mothers are the carriers. So one of the things that have come out of his research is that there's a screening test done now, and those mothers can decide whether or not to have their babies and whether to get pregnant even. Excuse me, I'll just check to see where I'm at. And the other study that talks about another type of relationship that you can have with Māori is the NEAC study, and that's a multi-ethnic New Zealand study of acute coronary syndrome. And that the person on your left is the chairperson of our group, and that's Anna Ralston. And the person on the other side of her is my friend Irina, and I just put her in there because I haven't seen her for so long. and what I really like about this kaitiaki group is that, it's made up of Māori experts, but also of non-Māori experts, and we all have a say in, what's happening, but the control sits with us, with the kaitiaki group really. So they come with reports to us, and we just decided what kind of information we wanted reported to us, and so we can track their progress. I think they might be finished too, and they're writing papers and stuff like that. So that's a different type of relationship. So you've got Stephen's one with the whānau, the individual whānau, which is close and has existed for many years, and this kaitiaki group that is managing the NEAC study. There are other examples of this in play too, and other examples of when some of the researchers go out to the communities and work with hapu and iwi to do something that they've specifically asked for, and these relationships are also ongoing. I kind of like this one as a researcher. So when I'm looking at an application, I ask myself, can the investigator demonstrate they know the topic area that they're going to research? For example, if they're doing research about diabetes, do they know Māori are almost twice as likely as non-Māori to present with diabetes? Do they know Māori present at a younger age 30? Do they know Māori are less likely to get quality care? Do they also know that Māori men are 10 times more likely and Māori women 13 times more likely to die from diabetes or a diabetes-related illness? And more specifically, and I was sent this document by somebody who's sitting in the audience, do they know Māori are 5 times more likely to experience renal failure as a consequence of diabetes? New Zealand Nephrology 2015. Yet in 2015, of the 24 New Zealanders who received a kidney transplant as their first point of treatment, none were Māori. The other thing also is if people are looking at cardiovascular disease, does the mortality and morbidity rates play a part? And sometimes they don't. Do they know Māori are more than twice as likely to die from cardiovascular disease and less likely to be hospitalised? Does the treaty play a part? For example, Māori have equitable access to heart transplants and angiograms now, and the pharmacogenetic research studies that Patrick Gladding's been involved with are ensuring that Māori are getting the right medications for if they've got DNA mutations. The other thing I ask myself is I look at the methodology, and some of you look like you're going to sleep. Yawning away there. So, typically if it's a kaupapa Māori research methodology, you can kind of think that, in my mind, that they'll address all the issues that are of concern to us when we're reviewing research projects, but typically they're not. And so we have to find another way around it. The other thing for me is that, you know, quite often we ask, how are you recruiting Māori? Because part of the treaty is to ensure that Māori are well represented. And so Marianne and I have talked about this, and I've talked about this with the research committee. If we're talking about clinical trials and there's only maybe 1 or 4 participants, and maybe none of them are going to be Māori, what does that mean, you know? Do we still have to go through the whole consultation process? Probably not. And we do have something in place for it, but I just thought I'd put it out there to think about. And so when I ask, you know, how are you recruiting Māori and there's only 1 or 4 people, well, you know, I kind of wonder why I'm asking that question, because there aren't going to be enough Māori in there to make a difference for Māori health. And that's something that's also sitting out there in Māori, in the Māori ethical domain, or the Indigenous ethical domain. And I'll probably talk about it down at Ministry at the end of next month. And, I just thought you might like to look at this, because this is something that quite often comes up in the clinical trials arena. And just think, I'll talk to somebody next to you really about what your thoughts are. What do you think it means? I'll give you 1 minute. I think I've got 10 minutes. Does anybody want to comment? I think for me, I just go, oh, grief. Because, of course, the same opportunity isn't about making a difference. It's about maintaining the status quo. And it took me 2 years for one group of clinical researchers to change that. And just recently, one of the others, so that's maybe 5 years. Which brings us to tikanga Māori. And that's about te ara tika really, and I'm really glad I'm not talking about that today. Otherwise I'll be repeating what's already been said. So in terms of Ngāti Whātua tikanga, you know, do the researchers know that Ngāti Whātua don't want their tissue sent overseas? Or if it is sent overseas, do they know they want it sent back? And if not, what mechanisms do they have in place to address that? I'm not sure if that exists in other iwi boundaries or not. And finally, what does tikanga look like in practice? I'll just read this. So do the investigators know Ngāti Whātua are the local tribal authority and what this means for them? Do they know when to have a pōhiri or mihi whakatau? Do they know the importance of karakia and when to use it? The other thing, because I've been involved in the national Māori and international Indigenous discussions around informed consent, and one of the things that we talked about was true informed consent, which was about telling the truth about not only clinical risks but social risks and cultural risks. That doesn't sound very nice, does it? It's got a hiss to it. What's that about? Also, there's this thing about dynamic consent, and I see Dr. Sarah sitting in the audience, and one of the things that her and I debated was, what's that, you know? And she, the Starship teams do it all the time. And it's really about saying to people, every time you see them, do you still want to be part of the study? And it's just their normal practice. The other thing that might be useful for researchers to know is who are the Māori health teams in both the district health boards, and what are their roles, and can they play a role? Have cultural contact details been given to Māori participants, or will they be? And I've already talked about whānau as part of the consenting process. And the big issue at the moment is what's going to happen to the tissue and then what's going to happen to the data from the tissue. And we're still debating that. Some of the researchers who have Māori on their team have contracts that outlines what's going to happen to the tissue and the data. And so, in summary, for me, the Māori review is about te treaty o Waitangi, tikanga Māori, and the nature of our relationships. Any questions? Oh, that person down there. Hi.
Can you just talk through the process of when the baby cards went over to the University of Auckland? What was that process that was decided on after much discussion?
Sure. Some of you may already know this. So we had what's called a purupuraki, I suppose. When it was time for one of the first baby heart to be taken over to the university, the Kaya Whina came in and did a karanga over all the baby hearts in that registry. And then the consumer rep, who's non-Māori, sung a waiata over those hearts. And then the kaimanaki, who's the male part of the team, did a mihi, and then the baby heart was lifted onto the gurney. And the pediatric cardiologists, the clinical nurses, the Māori Health team, and the researcher walked following that baby's heart, and the researcher put his hand on the trolley and stayed connected to that baby heart, and the kaimanaki did the karakia, and it was just an amazing sound as we went through those halls and the karakia was said, and he kept it going until the baby heart was put on the MRI table at the University of Auckland. And after that process, it was very touching, and the cardiologist, the head of the cardiologist team, was really grateful that we were able to do that with the Chief Advisor Tikanga's support. And now that the study's finished, we're going to bring the last baby heart back and shut everything down. Anything else? Thank you.
One more question over here.
Oh, sorry.
Hi, you just mentioned data, and I'm interested in Māori data sovereignty, and in particular as we move to cloud-based storage of data and the providers being overseas.
Can you, prior to it going overseas?
Yeah, so with the potential storage of Māori data overseas, but in particular reference to cloud-based solutions.
Yeah, I can't answer that one because we're still talking about it, but apart from that, it's a little bit outside my scope. I haven't quite got the answers yet. Sorry.